So, pleasure to be here this morning. Thank you, Runcie, who is doing just such an incredible job with this organization. And it's great to see my colleagues from MD Anderson, so terrific. And then from Kansas, so it's really great. Thank you guys for all being here this morning. What a great turnout. So in my 20 minutes, and I'm just going to make sure that I am adhering to that. I'll put my watch right there. Sometimes, you're up here and you just go on, but I'm not going to do that. So my agenda today will be to talk about what a PARP inhibitor is, how these drugs work, and the different agents that we're using in the clinic currently. Briefly talking about how PARP inhibitors are being used for women with newly diagnosed disease, really talking about kind of on the heels of what Dr. Sood has presented, and then presenting at least some of the schemas of the studies that are going to be presented this weekend at the European Society of Medical Oncology. How PARP inhibitors are being used for recurrence, although this is not such new news anymore. This is older news, so I'm not going to dwell on it too much, but briefly talk about it. And then what are the future for PARP inhibitors now that we're using them up front, and we're going to be doing that increasingly so. Talking more with Dr. Sood already talked about in terms of PARP inhibitor combinations. There's a lot of work going on in that arena. So what are PARP inhibitors? That's what PARP stands for. It stands for poly-EDP ribose polymerase. And these are proteins, enzymes that assist in the repair of DNA. And every day, tens of thousands of DNA damaging events. So your DNA is being damaged constantly within cells. And the cell has to figure out a way of repairing that. It's a very complicated process, but it's really exploited by the use of PARP inhibitors, since cancer cells sometimes have deficient proteins or lack of some proteins that allow it to repair the DNA. And if you can't repair something called a double-stranded break, the cell can die. So PARP inhibitors interfere with DNA repair, and if that DNA is not repaired, as I just said, that cancer cell can die. So this is sort of bringing you back to biology 101. So PARP inhibitors work in a few ways, but the two main ways are listed here. One is that they inhibit that enzyme PARP. And remember, PARP is important in fixing single-stranded breaks. And then secondly, and importantly, the PARP inhibitors cause the enzyme PARP to get trapped and stuck and glued onto areas of DNA break. I list here the 5 PARP inhibitors that are in clinical use right now. The middle 3 are being used in ovarian cancer right now. The one all the way to the right is a drug called talazoparib. That's been approved for breast cancer. And is also being used in ovarian cancer clinical trials. The drug all the way in the left is a drug called veliparib, and veliparib is a drug that's being tested in one of the clinical trials that's being presented this weekend at the European Society of Medical Oncology. So the middle 3, rucaparib or Rubraca, olaparib or Lynparza, niraparib or Zejula. Those are all 3 in the middle. And at the bottom, that red line is something called the ability to PARP trap, so PARP trappers. And the thicker the line, the better the PARP trapping ability. So talazoparib is a great PARP trapper, very, very good. Veliparib, all in the left, so-so. But the 3 in the middle, olaparib, niraparib, and rucaparib, all are pretty similar in terms of PARP trapping abilities. And I bring this up because the better the PARP trapper, the less ability you can combine that drug with chemotherapy because of overlapping bone marrow suppression. So it's just something to think about as we're designing clinical trials. Okay, so how do PARP inhibitors work? There's a little schema. So on top of that twisted piece of DNA, you see a break. That's called a single-strand break. And then a PARP inhibitor, the PARP enzyme travels. I call it a first responder, and that's how I explain it to patients. It's a first responder. It goes to the site of that single strand break, And what I'm not going to show you, though, is there's a host of other proteins that come as kind of secondary and tertiary proteins to help start to repair the DNA. But what's important is that once that PARP enzyme sticks to the DNA, it's got to drop off. And if it gets trapped, that's a problem. So here you see the PARP inhibitor in orange. And the PARP inhibitor is gone to the PARP enzyme and is causing the PARP enzyme to get stuck onto the DNA. It can't drop off, and therefore other members of the DNA repair family can't get there, and you get basically increase in double-strand breaks. Single-strand breaks can be repaired. Double-strand breaks, the cell has to repair those double-strand breaks. If the cell doesn't repair the double-strand breaks, it dies. Most normal cells have proteins such as BRCA1 and 2 that help DNA repair those double-strand breaks. But for example, if you have a cell that does not have a normal BRCA protein or other proteins within DNA repair that can't fix those double-strand breaks, the cell can die. So that is, in a sense, something called synthetic lethality. I know I'm teaching a lot of biology today, but these are really important concepts of how these drug works. So when I was sitting at an American Society of Clinical Oncology meeting, ASCO, in 2008, I saw this data for the first time. It was a phase 1 meeting at ASCO, so 2008, it's a long time ago, and saw these scans really showing a few patients with heavily multiply treated ovarian cancer who have underlying BRCA mutations, and there was actual anti-cancer responses to the drug olaparib. So when I was sitting in that meeting, I knew that these were going to be super exciting drugs, and that our group had to become involved. This is one of the first trials. These are Dr. Sood explained a waterfall plot, so I don't have to explain the waterfall plot concept again. But all the way on the right, where that blue box is, are women who really are benefiting the best. So these are all women who have recurrent ovarian cancer, have an underlying, actually had germline BRCA mutation, and about a third of the women had very good responses to the single agent PARP inhibitor, and typically their responses lasted around 300 days. So that was really the clue to us that these were going to be very exciting drugs. So again, another concept that's important to remember as you're thinking about PARP inhibitors is that cancers that have underlying BRCA mutations that are considered deleterious. You heard from Dr. Liu that there's also these entities called variants of uncertain significance, but true mutations that really ruin the protein, deleterious mutations, those are the cancer cells that are going to be the most sensitive to PARP inhibitors. Then there's a middle group that we call HRD positive, homologous recombination deficient, meaning that they may not have a BRCA mutation, or they may, but they have other proteins involved that are abnormal that might give rise to that cancer cell being sensitive to PARP inhibitor. And then all the way on the other end of the spectrum are cancer cells that are probably not going to be sensitive to a single agent PARP inhibitor, and those that are have the ability to repair DNA and have normal BRCA proteins. I'm going to refer back to that again. So currently, who is eligible to receive a PARP inhibitor? Again, this is kind of where the FDA stands with regards to the use of PARP inhibitors, specifically in the United States. A little bit different than Europe, but here in the United States. So for newly diagnosed ovarian cancer, and I'm going to also show this data, Dr. Sood also showed this before, this is based on the SOLO-1 data, where you saw this really impressive keeping the cancer in remission more with the use of olaparib versus placebo in patients with newly diagnosed advanced high-grade serous ovarian cancer. And you do need to have an underlying BRCA mutation for that. But it could also be a somatic or a tumor mutation that Dr. Liu said. So we think about mutations, most of the time we find the mutations in the germline, like every cell has that mutation. But sometimes the mutation might just show up in the tumor. So it's really important to check the germline from blood and then check the tumor as well. For recurrent cancer, PARP inhibitors have two main FDA approvals right now. And one is through maintenance treatment. So somebody has recurrent ovarian cancer. They are in response to reuse of carboplatin chemotherapy, And then once that individual is finished with the carboplatin-based chemotherapy, they can then go on a maintenance PARP inhibitor. And all 3 PARP inhibitors have that indication, and that's rucaparib, niraparib, and olaparib. You don't need any markers, you don't need any tests. Basically, recurrent cancer and in response to platinum-based chemotherapy. As I remember I told you, you can't put PARP inhibitors together with chemotherapy because there's overlapping bone marrow suppression, and you need to do them sequentially. And then lastly, which is treatment for recurrence, was really the first way that PARP inhibitors were approved in the United States, and that first approval was in December of 2014. That was olaparib, and that was for patients who have recurrent, heavily pretreated ovarian cancer. They had to have a germline BRCA mutation, and that's olaparib. And rucaparib has also got that indication as well. So that's where we stand currently. Dr. Sood already mentioned to you this SOLO-1 design, which now has enabled us to use PARP inhibitors in women with newly diagnosed ovarian cancer. The patients enrolled into this trial had to have advanced high-grade serous ovarian cancer, so stage 3 or stage 4, have an underlying BRCA mutation that could either be through the blood or through just the tumor, and they had to have a response to the chemotherapy. So they had to have evidence that CA-125 was going down, CAT scans were improving, etc. Women were then randomized 2-to-1 to either olaparib or placebo, and there were about 260 women receiving olaparib and a little over 100 receiving placebo. And the duration of time was 2 years. So if somebody was in a clinical remission, at 2 years they stop the olaparib. If there is still evidence of cancer, they can continue it on. And the primary endpoint was how investigators or how physicians were assessing how well the cancer was being kept in check. And the results, Dr. Sood already mentioned this, he stole my results, but that's okay. 70% reduction in the risk of recurrence of the cancer by taking olaparib, and that quickly led to the FDA approval in December of last year. So, what's coming up this weekend? You'll pick up the newspaper, you'll pick up the New England Journal of Medicine if you subscribe to it, and you're going to find 3 studies that are going to change how we think about newly diagnosed women. There are 3 studies testing PARP inhibitors in newly diagnosed women with ovarian cancer. The first is the Prima Trial, and that is looking at the PARP inhibitor niraparib. So high-grade serous ovarian cancer in response to platinum-based chemotherapy, 2-to-1 randomization of either niraparib versus placebo, and that goes beyond women who just have a BRCA mutation. So it's now, we call folks who don't have a BRCA mutation, BRCA wild type, or not mutated. So this is a really important trial. We already know, because a lot of times trials don't leave us in suspense. There's a press release. So there's a press release in July that said, the study met its primary endpoint of a statistically significant improvement in progression-free survival regardless of their biomarker status. The second trial is called Paolo-1, run by the French group. Isabella Ray-Cocar will be presenting this. And this is a trial for patients who have advanced cancer, newly diagnosed, or getting bevacizumab with carboplatin and paclitaxel. And then once they finish that chemotherapy and they prove that they're in response, they're randomized to continue Avastin alone or bevacizumab alone, or adding olaparib to bevacizumab. And again, we know, based upon press release results from August, it's slightly different if you read the fine print. That's the bottom sentence. The trial met its primary endpoint in the intent to treat population. So that's the whole population itself. There may be some foreshadowing of some differences between these results. So we'll have to see. And then the third trial is going to be presented by Dr. Coleman, MD Anderson. Is called the Velia trial, looking at the addition of the PARP inhibitor veliparib. Remember I told you veliparib is a weak PARP trapper. So here it's being added to chemotherapy and then continued as maintenance versus carboplatin paclitaxel alone. And we've also learned that that's also a positive study. So we'll get more of the specifics and kind of the magnitude benefit. And then the 2 other trials that are ongoing that are still enrolling folks. Some of you may be participating. These are the treatment arms. And then those are the maintenance treatment. I'm not going to go on because I want to finish by 11:15. Talking about the side effects of PARP inhibitors, there are some overlapping very side effects that are common to all of the PARP inhibitors: drop in blood counts. The FDA package inserts say that blood counts need to be checked at least monthly. There's a very, very small risk of leukemia. So, for example, in the SOLO-1 trial, there are 260 women enrolled in the olaparib arm. 3 of those women ended up developing acute myelogenous leukemia, or a pre-leukemic state called myelodysplastic syndrome. So it is rare. It happens. You have to be counseled about it, but it is a very small risk. Gastrointestinal side effects: nausea, vomiting, diarrhea, constipation, etc. These side effects tend to get better with time. Fatigue is another big problem. And in each PARP inhibitor can have its own unique side effects. So olaparib, for example, can cause interstitial lung disease, so pneumonitis, inflammation of the lungs. Rucaparib can cause a transient increase in liver function tests, which is not particularly significant, elevated cholesterol, and also a rise in the serum creatinine. That's because of its interactions with the OCT and MATE proteins. Olaparib can do that as well. And then niraparib can cause a slight increase in high blood pressure, sometimes heart rate as well. Something to be aware of when you're starting to take the drug. Again, none of these side effects would preclude use of the drugs. It's really just for information. And each PARP inhibitor has a different schedule, pill milligram strength, metabolism, drug-drug interactions, and half-life. So it's important, I think, for all physicians who are prescribing these drugs to look at the FDA package insert, learn about these drugs. And these are all package inserts that are available online. Okay, in the last few minutes, I want to talk about the future of PARP inhibitors and really extending PARP inhibitor use in ovarian cancers that do not have underlying DNA repair problems. So that's the first piece. I talked about those. You wouldn't really expect the inhibitors to work particularly well. Or for somebody who's been on a PARP inhibitor, done really well, but then the cancer starts to grow again. And that's really by this diagram, by adding another agent to kind of reinduce the concept of homologous recombination deficiency, or reinduce problems within repair of DNA. And that can be through anti-angiogenic drugs, as Dr. Sood mentioned, or immunotherapy combinations. So these are some examples of the combinations. Again, Dr. Sood stole my thunder, but talked about sedative olaparib, which is fine. This is a trial that Joyce Liu and my group started when she was a fellow in 2009. And this combination is currently in phase 3 trials, and hopefully will report out by 2020. So it's taken, again, these trials take a long time to mature. Then there's a whole body of work that we, the folks at MD Anderson, Memorial Sloan Kettering, a few others, worked on a Stand Up to Cancer project on a PI3 kinase pathway. And this was a really, I think, very productive group. We put together PARP inhibitors with this class of drugs called PI3 kinase inhibitors, and I think they're finally moving forward. We're also starting to do triplets, PARP inhibitors, immunotherapy drugs, and anti-angiogenics. Those are ongoing right now. And Anil also mentioned the combination of PARP inhibitors plus immunotherapy drugs. And this is the Tapasio study. This is run by my colleague Panos Konstantinopoulos. This came out of another Stand Up to Cancer dream team, an ovarian cancer dream team, led by my colleague Ellen D'Andrea and Dr. Swisher from the University of Washington. And it was, again, a whole bunch of folks. MD Anderson was involved, University of Chicago. It was a really great group. And this led to, again, the reason for putting these two drugs together, and you've heard this already from Dr. Sood, that single-agent immunotherapy drugs like pembrolizumab, you've see the commercials on TV, Keytruda, works really well in lung cancer. And I've highlighted a trial that we did, just under 400 patients internationally. We saw about an 8% response rate, so very low. So the whole concept here was to put these two drugs together to induce a better response. And that's exactly what we saw. And in some of the work from a lab at Dana-Farber, from Jean Zhao, but also others, showed that by putting these two drugs together, you activate something called the STING pathway, and that allows gamma interferon to be produced and T cells, hopefully, to infiltrate into the ovarian cancer. And where we saw the best responses on this waterfall plot in teal are patients who have highly platinum-resistant cancers, but that do not have underlying BRCA mutations. And those results have led now to the implementation of a trial called the Moonstone study, which is using niraparib plus another PD-1 inhibitor called TSR042. And that study is just starting, so really, really excited about it. Panos is leading that, and a colleague from UC Irvine. Just a couple more slides. These are examples of combinations of PARP inhibitors. They've all been worked out in phase 1 trials, but they're now in phase 2 settings for women who have received the PARP inhibitor, done well, but then the cancer starts to grow again. And the first one is led by Rob Coleman and colleagues at MD Anderson. We're fortunate enough to be participating in it as well. It's a combination of olaparib and a drug called a WEE1 inhibitor. And then the second is led by one of my colleagues at Dana-Farber, Kondo, adding a CHEK1, CHEK2 inhibitor called prexasertib with olaparib. And these are both open. So if somebody comes to me for an opinion, they've been on olaparib for a while, or niraparib or rucaparib, and the cancer is showing progression, these are good trials. And then lastly, second to last, is really trying to, as we're getting all these combinations through phase 1 trials into phase 2 and maybe even phase 3 settings, how do you pick the right combination for the patient? And I took this from a review that's almost published, but not quite published, from one of my colleagues, Jen Veneris, that to try to, and it's a complicated slide, but basically trying to pick the combinations that are going to be right for the cancer, the underlying cancer, and what problems that underlying cancer may have. Are there immune problems? Are there DNA repair problems? So hopefully we will, next time we talk about this at this conference, we'll have more data. So in conclusions, PARP inhibitors are now being used to treat women with newly diagnosed ovarian cancer in addition to recurrent ovarian cancer. The side effects of PARP inhibitors include drop in blood counts, fatigue, gastrointestinal side effects, and there really are some side effects that are uniquely present with each of the PARP inhibitors that we use. PARP inhibitor combinations are now being tested for women whose cancer may not be predicted to respond to a single agent drug, or for those patients who have responded well and they're now having cancer progression. So thank you so much, and it's a super pleasure for being here today.